Okay, good morning, everyone. It is 11 o'clock, so we are going to go ahead and get started. My name is Allie Wells. I'm the Communications Director for the Foundation for a Healthy Kentucky. Thank you for joining Health for a Change, the role of place in community health. I want to start off by thanking our two speakers who have dedicated their time and energy towards this webinar today. Dr. Nancy C. is the Dean of School of Arts and Sciences and Chair of the James R. L. Diggs Department of Sociology at Simmons College of Kentucky. Dr. Ted Smith is the director of the Center for Healthy Air, Water, and Soil at the Christina Lee Brown Envirom Institute at the University of Louisville School of Medicine. I'm going to turn things over to them in just a few minutes, but first I have a few housekeeping notes to go over with you all. If you have any questions during the webinar, you can put them in the chat or the Q&A, and we will address all questions at the end. There are no pre-approved CE credits attached to this webinar. However, I can provide a certificate of attendance for participating today. To get that certificate, you must stay on the full duration of the webinar. You must be registered under your own name. If you joined using a coworker's link, it will be their name that comes up in our attendee report, and we won't be able to verify your attendance. And certificates are only available for the live webinar today. While most of them are recorded and available on demand later, we can't verify viewings of the recording. So you can scan the QR code that's on your screen right now. It takes you to a very short form that you fill out to request that certificate. It's just filling out your name and the name of today's webinar. I will also put a link to that form in the chat in just a minute. And I will include all these instructions in a follow-up email tomorrow, and that will also include a link to today's recording in case you want to go back and watch anything again. A little bit about the Foundation for a Healthy Kentucky. We are a nonprofit organization funded by an endowment. Our mission is to address the unmet health needs of Kentuckians, and our two focus areas are access to healthcare and children's health. We do our work through policy advocacy, we build partnerships and bring together constituency groups. We fund research and data, and we fund and support community interventions and projects to improve the health of Kentuckians. I'm going to stop sharing my screen. So we are really excited about the topic of today's webinar and the chance to raise awareness that health is more than health care. Dr. C and Dr. Smith have done some really important research that dives into how the characteristics of a neighborhood contribute to the health of its residents. So with that, I am going to turn things over to them.
Great. Thank you so much, Allie. Really appreciate it. Let me get this slide going. And hopefully everybody can see it and it will be full screen. All right. Well, thanks everybody for making the time today. I'm Ted Smith. I'm a professor of environmental medicine at the University of Louisville School of Medicine, and am part of an ambitious joint effort with Simmons College of Kentucky and Dr. C on a multi-year journey to, I don't want to be too dramatic about it, but maybe rethink a little some of the assumptions about our broader environment and our health outcomes and health disparities. And so we'll do the quick sort of reprise for those of you that aren't familiar with the full journey we've had, certainly as a country. But if we go back to the 1950s and 60s, and even into the 70s, when many currently practicing clinicians are still seeing patients, this is the training that they received. This was an era that was largely, our understanding of chronic disease was largely understood as kind of the responsibility of the patient. And it really is a troubling time. And I'd like to say that it's completely gone, but there's plenty of evidence today available all the time that we still, have a lot of remnants of, us shifting the sort of blame for health outcomes to just strictly individual decisions, initiative, and behavior, or access to the healthcare delivery system as being the thing that is responsible for making people healthy. And so I think we all know that the journey, has taken us out of that place really sequentially over many decades to get to where we are today. And, it was sort of a broadening of the understanding of what was originally individual circumstances, which really still had the individual in the picture, as kind of an important actor. Then moving to like some very large scale epidemiological data that was very difficult to ignore, that really showed that people in just strictly different circumstances, different locations on the planet, different social hierarchies, were having, meaningfully different outcomes. And so that set the stage for a much more rigorous, kind of a review of administrative data. So this, gets you to, kind of the underlying work that was, we all know in the county health rankings, and the county health rankings had, figured out that there were many factors that were associated with different health outcomes, and that got us to the social determinants of health. And this, as I said, has been a many decades journey. But I guess I'd like to share, I think our interest is, kind of, I don't think anybody declared the journey over. And so, what we're sharing today is, what we think is sort of the next level of work that really is tied to improving health outcomes, reducing health disparities. And really, the starting point for this project, at least from my perspective, was, taking a look at, what I think people have really, internalized in some way, that, these factors, kind of that are in the middle of the equation, the health behaviors, the clinical care, the socioeconomic factors, and the physical environment. There was a time that these percentages were put on these things, right? And so and if you really want to dig into the history of it, there was a Delphi session with a bunch of experts around a table, and they, came up with these percentages. And it's a little bit troubling, in my day job, when I see the physical environment, and let's just pick on air quality, that's 10% of, kind of health outcomes, according to this model. And then it's been very difficult as we've worked in various parts of Kentucky where there are significant air pollution issues that are causing rare cancers and a variety of cardiometabolic problems. It's been difficult to get the attention of, the larger public health system, that this is a really important thing because, I've been told it's only 10% of the outcomes, so we probably should focus on some of the other things. So that, that was kind of a wake-up call that, maybe we should just revisit this a little bit. And that's really the spirit of this. It's in some sense to put all that good work kind of back on the table. And let's look at all of those factors in light of all of that we've learned, through research and practice over these intervening decades. And so, this is the model we have today, Healthy People 2030. It has, these big buckets, in our community here in Louisville, a lot of the a lot of the public health work and a lot of the insurance-backed work, it continues to focus on sort of three determinants: access to healthy foods, housing stability, and access to transportation. And the majority, I think by far, of initiatives in the social determinants of health have been in those categories. And it may have come at the cost of other very, very important things. And so I think these policy matters that have roots in a research process are always worth checking, and sort of making sure that we didn't miss anything, because we continue to have remarkable health disparities across Kentucky. We have remarkable health disparities in Louisville, where we are. And so I'm not I'm not feeling encouraged that we've made a lot of progress in applying these upstream important determinants of health in a way that's really moving the needle. And so, our proposal here is to evolve this kind of current framing of the data, and that's both the data sources and the scale of the data, to evolve it to kind of a different frame. And so, one sort of an easy conversation, which is, working at the county level with data for many, many communities is perhaps not the best level to work with. And a lot of our administrative data, unfortunately, is only available at the county level. And that, of course, then, what you have is what you work with. And, so we think there's a real opportunity to push harder into data sets that can get you down to zip codes and census tracts and census blocks and, getting closer to the unit where people live. And so our work has largely been focused on the concept of a neighborhood, as you might find in an urban or suburban setting. But those same ideas apply to small towns and other communities where you have, community, some density where people know each other and there's many different roles in a social infrastructure. And so really let's shift it and what can we learn about place from looking at that unit? Okay, that's one big idea out of this work. The other big idea, I think, is, really trying to shift the focus from administrative data, sort of all the record keeping that we as public health professionals are very used to relying on to make assessments of health status and health risk, to think a little bit about what might be being missed by using just that lens. And I think there's two important factors that we have focused on. One is administrative data tends to have a deficit orientation, is negatively framed. And by that, I mean, we're really defining communities based on the things they don't have. And we have very little understanding of when they have things that are, at, higher levels than bad, for one of a better way to say it. So for example, we don't know in a community that has three grocery stores, whether that makes any difference over, one grocery store, because we only know about communities that don't have any grocery stores because we call those food deserts, and there's a statistical kind of definition for that. And so we don't have the full understanding of food access because we're negatively oriented. And I think the other thing to know is that also means we're by definition not keeping track of other kinds of things that occur in community that are we can think of as assets or resources that really can be health protective. And there, of course, there's a giant literature on health protective components in a social system, and whether those are houses of worship or whether those are vibrant community organizations or many many things have been demonstrated to I don't want to say counteract, but certainly interact with deficits that are in communities to create better health outcomes than you might predict by just looking at the deficits. So this is the big framing for the work that we're going to, working at the neighborhood level, and that we're really going to have to look for, more critically, the data that might be missing from view. And so, this is sort of repeating a little bit of this. So we're gonna get to neighborhoods, and that includes, small cities and some rural communities. Again, it's what is your community? How do you identify, the place where you have your neighbors and, where you rely on each other for, community cohesion. And then, let's go looking for positive factors that might be missing because they may not be tracked in administrative data sets in a health frame. And so, what will those things be? How will we find them? How will we quantify them? And so the catchphrase, for the work that we do, which a long time ago sounded like a good idea. I'm not really sure if it's still a great idea, was this notion of a universal basic neighborhood. And it was really inspired by a lot of the political rhetoric we heard years ago about things like a guaranteed income, a universal basic income. And there's still groups across the country that are really earnestly trying to figure out, how such a thing could, be possible, because there is some evidence and real evidence that, people that don't have financial resources often trade off their health, for other, more immediate practical things. And so it's not crazy to imagine that providing financial resources is a strategy towards reducing health disparities. But it has, kind of one of these problems that I'm concerned about, and that is um, trying to improve public health one person at a time. And, I work in a school of medicine. We deal with patients one patient at a time. They come into our emergency room, and that's how we do medicine. It's also how we do health insurance in this country, one person at a time. What benefits are you eligible for? What is your treatment plan? Kind of. And I guess if we add every individual up, we'll get to the public, right? But I think the trick there is we do all that work without ever really thinking critically about where that patient lives. And we have this, kind of idea. Here's the sort of framework that, we all live in different communities that have kind of different ratios. I call them assets and liabilities. That's maybe a little too of an accounting term, but every neighborhood has strengths and weaknesses. And we know that many of those, if not all of them, are related to health outcomes. And so having a framework that says, hey, let's try to keep track of all those assets and all those liabilities. And could there be, kind of a minimum, kind of mixture of those things that really helps support good health and really does reduce disparities. And so, one of the catchphrases is that, we like to shift from diagnosing and treating people to diagnosing and treating places. And I think any of you all who know the great stories of treating drinking water or wastewater or garbage removal or public education, these are system-wide shared resources. They are not administered one individual at a time. I don't have my own water treatment plant at my house, and my neighbors don't either. We rely on the water utility, which at scale produces clean drinking water at a fraction of the cost of each of us having our own water treatment system. And so, this idea is a powerful idea. What are the things, that we should be focused on at that community place level? And so, that's the idea. So what do those neighborhoods look like? How should we back them into evidence-based frameworks to get some comfort that there is a connection between the kinds of diseases that are prevalent to the kinds of circumstances that folks are living in? And I have this little bright red box down there that is, it's kind of one of our mantras on the team because we know that I'll call it a bad habit in public health of comparing places to each other. And quite frankly, the county health rankings encourage that kind of thinking, right? How did that county have such unbelievable outcomes and that county so bad? And we're talking about just comparing them to each other as if they were really in a common frame, which just simply isn't true. And so here in Louisville, we talk about a 12-year life expectancy difference between a community in West Louisville and a community in East Louisville. And then that sort of immediately trains the mind to go, think about that community in West Louisville as not being as good as that community in East Louisville in some way, which honestly, it's going to be hard to imagine we'll make any progress trying to work like that. The goal isn't to try to make every place like that other place. So we like to think about the real application of this work is to be in a place and try to help that place be its best version of itself, right? I mean, it has its own characteristics, it has its own, kind of constraints. Maybe it's next to the river, maybe it's, near a factory, maybe it's near a golf course. I mean, we can't make homogeneous universal neighborhoods. They all look the same and they all work the same. So, we need to look at each place in a pragmatic way and say, well, what are the things we need to work on here? What are the problems that we need to address, and what are the assets that we need to really double down on and encourage more of? So that's kind of the big idea. A lot of this is sort of 30,000 feet conceptual framing, but it will set us up for my colleague, Dr. C, who in this partnership, which started, I think, 4 years ago, maybe five, with some support from the Robert Wood Johnson Foundation, you know, uh, we needed a partner on our side we use a lot of administrative data. We needed a partner who really understood qualitative data methods, who understood assets and resources in communities. And Dr. C has led an amazing enterprise at Simmons College, doing that work for a very long time and doing it extremely well. And so I am going to turn it over to her to share a little bit about how that work works. And thank you so much for your attention.
Hello, thank you, Ted, for that introduction. I'm Dr. Nancy C., and I am at Simmons College of Kentucky, a growing HBCU in Louisville, Kentucky. We were brought into this study to look at what is a universal basic neighborhood. And one of the ways that we can look at it is through an epistemic justice framework. Whose voices get to be heard when we're carrying out research? And you'll see it quite a few pictures. I'm really proud of the work that we've done in different parts of Louisville, uh, working with the University of Louisville. If you advance to the next slide, and we'll talk about the work. When we talk about epistemic injustice, which was Miranda Fricker's research back in the 1990s, it speaks about unfairness and who gets to be heard, who's believed, and who is understood as a knower. You know, when we're getting into how do we deal with other people's ways of knowing. There in the background, in this picture, we see some of our students with a neighborhood resident who is teaching them about their ways of knowing and about their neighborhoods. Next slide, please. How do you implement epistemic justice in concert with place-based community health research? And that was what we grappled with as we began to approach our research for the universal basic neighborhood. Now, you look on the left, and there are some traditional approaches that we see in health research, public health research, an individual focus. And Ted made that pretty clear. We treat people one at a time. There's a preference for large R1 type research institutions. And so we believe them. You know, who do we believe in these traditional approaches? They have all the experts, and we believe these medical experts. And I'm not making light of any of these, that we need them, and we ought to have them. Uh, Large amounts of administrative data, and Ted talked about that, especially quantitative data that's been generated from these large data sets, if you will. And then Ted also brought about these deficit based approaches. So when we look at places, and our focus was neighborhoods because Louisville is divided into some well known neighborhoods, and people understand themselves as residents of neighborhoods. And so, but often we enter into a neighborhood thinking the neighborhood is the problem. In contrast, the UBN approach is community or at least neighborhood focused. And neighborhoods in the sense of bounded places. Our approach includes, now we're not throwing out the traditional approaches, but we're including more, includes smaller non-research institutions like my institution. Uh, we take a transdisciplinary approach. In our first UBN study, that was funded by Robert Wood Johnson Foundation, we took a real transdisciplinary approach. And so we had our public health people at the University of Louisville, but we also employed sociologists in this research. We had a law expert uh, teaching at at the University of Kentucky. We had political science people. And we had two community organizers that were working on our team, as well as getting input from social work. And so this transdisciplinary approach is including other voices. Ours prioritize community members' knowledge and experience, and we'll talk more about that. And then this layered data approach. And so we've got our administrative data, but then we can layer much of this qualitative data and other types of data to get a much fuller and broader picture of community life. And then finally, a resource-based approach. When we go into a neighborhood, we believe that the neighborhood has solutions that are already there, but we have to either recognize them or find them as we look into different communities. And so in the next slide. So we're reframing place through this resource-based lens, and we make certain assumptions about a neighborhood. And next slide. The first assumption, we assumed that there's tapped and untapped resources in every neighborhood. Not just some neighborhoods have resources, but every single neighborhood has some type of resource. This neighborhood, the pictures coming from this were from a lower income neighborhood in Louisville's West End. And we looked, and here's a bookstore right there. The historic institutions, the Baptist Church. One had a historic, a couple of historic Catholic churches that contribute to a very vibrant community life. And so we go into a community assuming that there's something there. The second assumption, moving right along, is that neighborhood residents are the neighborhood experts. There was a saying, I can't even remember who said it, but those who are closest to the problem are also closest to the solution. And here we used our students at Simmons, and we got some also from the University of Louisville to come alongside of us. And in our research, one of the first things we did was we took our students to the neighborhoods and we let them get acquainted with what we consider to be neighborhood experts. On the right, they're in the lower income neighborhood, and there's a woman. We call her the mayor of that neighborhood, actually, because she knows so much and she's so involved. In the other neighborhood that was higher income, we took our students there to learn from their community experts about the neighborhood. That was the first thing we did before we even began the research in the neighborhood. Now, our third assumption is that every neighborhood is unique. And think about that. Therefore, we don't make comparisons between neighborhoods, inter-neighborhood comparisons, if you will, but we do make intra-neighborhood comparisons. And when we talk about that, Ted hit on it. What is that neighborhood's aspiration? Where do they want to be? And so if we compare anything, it will be that how does that neighborhood live up to what they want to be, what they think is the best version of themselves? That way we avoid, when we don't compare neighborhoods, then we avoid that idea that we're going to make the whiter and the wealthier neighborhood the standard neighborhood. And if you could just be like this high income neighborhood, you'd just be fine. but we don't take other things into consideration that each neighborhood has developed uniquely. And then the other thing is that it's so easy to assume that your wealthier and your higher income neighborhoods are just fine. They don't need anything else. And by looking at each neighborhood on its own merits, allows us to see the assets of that neighborhood, but it also allows us to measure the needs of that neighborhood. Uh, the fourth assumption, and the final, is we assume that neighborhood research should make neighborhoods better. And going into neighborhoods, especially over researched neighborhoods, often they'll say, well, you're coming in here, you're getting all of our information, and what do we get out of it? You're writing articles and books, dissertations, but what do we get out of it? So the research first invests in neighborhoods by training and paying neighborhood residents for their knowledge, for their participation. The second thing that we do is we invest in the neighborhood resources. We go in that neighborhood, we're going to eat in that neighborhood. If possible, we'll shop at that neighborhood. We attend neighborhood events. And it's so wonderful that we do it together. The University of Louisville comes in with us, and we've made it a point that we do these things together. And then the research respects the participants' time and knowledge. We don't take our participants for granted. And finally, the research is actionable, that the neighborhood's going to get something out of it. I chose this picture here, and this is a picture, one of Simmons College of Kentucky's buildings is in the background there. And during the pandemic, we looked at the neighborhood, the Limerick neighborhood, where our institution is located, and we did asset mapping there. And it also helped that at the time, one of our research, not participants, but one of our researchers also was a city council member. And so one of the things that the neighbors, that the neighborhood complained about were the sidewalks. And I can say now, it's been about, 3, 4 years later, that we have streets and sidewalks that have been repaved all through the neighborhood, especially around our school. And that was a big thing, and our mayor was quite pleased with that. But also that work began even before he became mayor, as we began looking at these things in neighborhoods. And down in the corner, that was the research, student researchers that did that work for us. Okay, next slide. And then we're looking at the methodological contributions. We've leaned towards community-based participatory action research. And we're learning as we go, but if you'd like to know more about our methods, we'd be happy to share with you anytime. Now, here's some of our students that we're getting ready to pass out surveys door to door and doing the canvassing. They're at a local coffee shop right in the neighborhood where they will be doing the work. Next slide, please. And we've done most of our data collection has been with our students. It's really important. We are not an R1 or even an R2 for that matter. I don't know if we're even on the spotlight anywhere. We're not a research university, but we want to train the next generation of researchers. And so we're training our students, the undergraduates, This was one of the courses that we trained them in, and we're having a wonderful time. One of the classes was we had all our basketball players. Can you imagine that? And we were training them how to go out and do ethical research. All of our students are IRB trained and approved. They've taken the city training, and they are really learning things, and we're happy. One thing that we did find out, though, is that we give our students a little money. Now, for the class, we might give them, just not a great amount, but enough to make it worth their while. And often, the students in our classes are members of the community where we're researching, or communities very similar to those that we're performing the research in. Next slide, please. We are currently in our second study. Our first study, we were really trying to develop this idea of what is a universal basic neighborhood. We did the data collection, and we did it in a way that, like I said, with the epistemic justice in mind, how do we hear the voices of our neighborhood residents? And I'll talk a little bit more about each of these, but the first thing we did were the surveys. We went door to door with the surveys. That was followed up with focus groups. Why? Because the surveys informed the focus group questions that we were going to ask. And finally, we got into the key informant interviews. And many of our key informants were identified during the focus group interviews. We'd ask, who do you consider to be leaders in your neighborhood? From whom in your neighborhood do you get information? And that's where we were able to develop this idea of our neighborhood experts, our key informants. And then finally, at the very end, we had neighborhood report back meetings where we were able to get the voices of the neighborhood people to comment on our findings. Next slide, please. And these are some of the questions that we had on the neighborhood surveys. The students went door to door with these surveys. We call it canvassing. And these were designed that they could ask questions that would be answered in less than 15 minutes. We tried for 10 minutes, no longer than 10 minutes. And we developed the surveys that they could ask them the questions on their smartphones, and then it would go automatically to a database that was, a confidential database, if you will. The next slide. Then we did the focus groups, and this tells you we did 8 focus groups, 4 in the lower income African American neighborhood, 3 in the higher income, predominantly white neighborhood, and then we did a mixed focus group with residents from both neighborhoods, which was really, really interesting to find out how they reacted to each other. And it was a really good exercise. And this gives you a little bit of idea of what we did. The focus groups allowed us to get a more intimate look, and it also allowed us to refine some of the findings from the survey. The focus groups were administered by trained research assistants that went out, and then they were accompanied by a note taker. And it went very well. What else can I say? Okay, next slide. Then we had the key informant interviews. And as I said before, most of our key informants were identified in the focus groups. They told us these are the people who we trust. And I don't have a picture of the interviews, for confidentiality purposes, but here is our interviewer, Dr. Kamara Douglas, who is also a community organizer. So he understood the community and had very conversational interviews, and some really, really good things came up because we found that most of our, if not all, of our key informants were very, very pro neighborhood, no matter which neighborhood they were in. Next slide. The neighborhood report back events were very, very helpful. Um, Here we have in the left-hand corner was our legal expert. In the middle, we had our one of our researchers who's also a community organizer. We had two on our team. On the right, you see Ted, who's explaining some of the findings. And we went to both neighborhoods and two things. In the higher resource neighborhood, the administrative data uh, indicated that the neighborhood did not have a lot of green space and at least green space that could be used, and that it had very few park areas. And we got there and they said, the neighborhood residents says, no, that's not true. And then they began to name off places that the administrative data might not have identified as parks and things, but they used it. They used the school, which had a larger campus. There were also seminaries with beautiful sprawling campuses. They had some public areas that were not designated parks, but they were able to use it for walking. And so that really helped us. In the other neighborhood, the lower income Black neighborhood, we heard a lot of people talked about safety issues and the need for more safety. But then the residents, as we talked about that, they said, but what you don't understand. And they began to reframe it. They said, our neighborhood is pretty safe. We feel good around our neighbors and feel safe with our neighbors. But sometimes there are outside people that come in, and they're the ones that give our neighborhood a bad reputation. And so it was really interesting to get a different take on some of the things that we found. Next slide, please. Uh, for the second iteration, UBN2, we call it, we added a new data collection method because we wanted to know, how do people experience their neighborhoods? And so we added field observations and geomapping to also look at the neighborhoods and to physically identify assets, but also challenges and needs in the neighborhood. And once again, we developed a way that students could enter their findings, their observations into a pre-made database, just using their smartphones, something that they're really um, used to using. And then they were also able to geotag certain spots so that later on we would be able to put those in the asset maps. Next slide, please. So when we talked about aspirational, one of the questions that we asked each neighborhood is when we were talking to our key informants is, what is your personal vision for your neighborhood? And they came up with all sorts of things. Now, this was the lower income Black neighborhood. When I or my son or any random person Googles the Russell neighborhood in Louisville, I don't want the first article to be that. And they were referencing who got shot. Uh, Healthier food options for our neighborhood, right? More commerce, housing. And when I say housing, I mean desirable housing. And you can read these on yourself. Now, what I did with that is just to kind of get an idea, playing around with generative I fed all of these into the AI program and asked it to illustrate what their aspirational neighborhood would look like. Next slide, please. And here's what it came up with. Now, this is looking at Louisville's downtown from the western view. And you look and see, here's what they wanted. They fresh vegetables. They want a place where they can congregate, nice sidewalks and things so the kids can ride their bikes. Next slide. We asked the same question to the people in the higher income white neighborhood. And they said, we want more diversity. We think that makes our neighborhood healthier. And we want buses because this neighborhood had one of their main streets really was crowded. And because of the way the town is laid out, doesn't have the wide roads they need to support the many businesses on the street. And so one of them said, if we could just have a trolley, and because the neighborhood kind of sits in between this really vibrant downtown and then the more vibrant shopping area that's in east of this neighborhood, that they thought that transportation and green transportation in particular. And then this neighborhood was very, very socially cohesive, probably one of the more socially cohesive areas in the whole county. And they said, we want more. We want more social cohesion in a neighborhood. And so let's see what generative AI said about their place. Next slide. Okay. And here's looking at downtown Louisville from the eastern view. And AI threw that Ferris wheel in there for some reason. I don't know why. I couldn't get it out. And then I thought, well, maybe that's because, during Derby, they do put rides on Ferris wheels downtown. But look at this neighborhood. Now, one thing, this neighborhood kind of looks like the neighborhood that the people in the other neighborhood wanted too, right? And we found out that in both neighborhoods, for the most part, people wanted the same thing. Do I have another slide? I can't remember. Or am I done?
That was your last one.
Okay. Well, that's all, folks. Thank you very much for listening.
All right. If you have any questions for either of our speakers, feel free to start putting them in the chat or the Q&A box. Let's see here. I'm gonna get it. I can start, Dr. Smith, Dr. C. If there was one, did either of you have like a top key takeaway from your research, something that just stands out in your mind as something that was extra interesting to you?
Well, I think Nancy already shared with you the kind of what happens when you miss the administrative data, right? The look. I think I think a lot of us can get comfortable behind a desk, looking at spreadsheets and reports. And, when you actually sort of just test those theories about how places work, I mean, you really discover that you don't have any idea. And so, I think it's just, it's spending the time. And so, we've learned all kinds of things about all kinds of places, just by spending time with people who just see them very differently than you would if you loaded up a GIS software program. So, yeah, I mean, lots of stories actually.
Yeah, for me, it was the joy in the data collection. I know that qualitative data can be intimidating, right? Because you get so much. but it allowed us to really get into the neighborhoods and to get to know the people in the neighborhoods, and being able to teach it to the students as well. It really made it worth it to do that qualitative deep dive, and we're still looking for other ways to capture that information.
All right, questions have started coming in. One that I'm seeing a few times is how could this research, this lens be applied to rural areas? I know your focus was in Louisville, but how can you suggest to look at it in rural parts of Kentucky?
Nancy, you want to take it? You want me to take it?
No, you take it, Ted.
All righty. Well, it's interesting because I'll be in Marshall County this afternoon. So I'm thinking very much about other parts of Kentucky right now. You know, the very same methodology can work in a small town, in a small city, anywhere. You know, because really the unit is kind of the our social organization, right? And so people know where they live, and they have a sort of psychological set of boundaries, like that's not where I live. You know, that's another place over there, right? And so, the time that we're doing some work in Marshall County, you know, we've gotten to know residents, who, the neighborhood, maybe a little bigger than the neighborhoods that we're working in, using that language, but that's their social fabric, right? And people know how far is too far to go, for something. And same tools apply. So really spending the time where people congregate, where people kind of intersect, these methods can be applied there too. And I really am excited about the work. There's maybe a phase 3 of this project that is in other parts of Kentucky, where stay tuned for. I hope we'll learn some really interesting things.
Great. Someone wants to know what were your criteria for choosing the two neighborhoods that you focused on?
Um, for that particular study, we wanted neighborhoods that compare well. So we looked at how many people were in the neighborhood. And one of the other things is that we didn't want confounding factors in the neighborhood. So we chose a neighborhood that didn't have like 5 hospitals, for instance. And that seemed to compare pretty well. And we were really quite pleased that it did allow us to, even though we didn't compare one neighborhood with the other, but it allowed us to look at both of these neighborhoods um, in similar ways.
Yeah, and both of them were in our urban services district, which,
Um,
Louisville's a merged city county, but there is an original city. And the original city, which has, its, specific garbage collection and, all the things were shared between these two neighborhoods. So we were at the farthest east we could go without hitting, kind of a second class city that has its own police department, has its own, when you start to add those confounders, as Nancy mentioned, it gets very difficult to make these comparisons. So I think that was as much span as we could produce within the original city of Louisville.
A couple of people are asking the same thing, but in different ways. So I'll try to merge them together. Um, your findings, what does it look like in practice? Like how can we implement what you found in your research? And how likely is it possible that that will happen?
So let me jump in on from 30,000 feet, we did the first project with the support of the Robert Wood Johnson Foundation, really to just prove out the concept, right? And it was a little controversial. I mean, if you saw the first reviewers when we put the proposal in, the social determinants, are also maybe also sacred in some sense, right? And so it didn't go down easily to say, we really think we should be thinking differently about how this stuff works. And that doesn't disrespect the tradition. It's just to say, maybe there's other levers we can pull. So, that was sort of in the deep history, but it was really just to say, can we pull it off? I mean, there were people that accused us of boiling the ocean, right? Like you're going to just try to get all this data and you're trying to figure it all out. That was, I think we successfully said there's a way to contain this and make it practical. We're in a second phase right now, as Nancy mentioned, focused on social isolation and loneliness in seniors. And we're looking at the UBN kind of framework as a way to think differently about loneliness. And it's a global epidemic, and it's not just for seniors. I mean, loneliness and social isolation is a big deal, and it has a huge health burden on the other side. So, practically speaking, that's an implementation project. So, now we are experimenting with a couple of different implementations. For example, looking at the built environment around senior centers. Some of them, I don't mean to be disrespectful of the industry, but like looks more like incarceration than care. And so, even making small changes to the physical arrangement inside and outside these facilities, we see tremendous opportunities to really improve health. And so there are any number of examples, and it really just comes down to having a lens to say, what's the problem you're really trying to address? And I think if you're clear about the challenge, the implementation gets a lot clearer too.
Another part of that, though, is putting a face on the research to affect policy. And even though we do not directly, because we have to work in certain parameters, that we're not going out to directly change policy. But I do hope that the work that we do will indirectly get to policymakers to understand the full scope of what people are experiencing in their communities.
I think this will probably be our last question. What feedback did you get from student participation? How did they enjoy working on this project with you all?
We got really good feedback. The I told you with the basketball players, I said, did we make a big mistake, with these guys going out? Some of them had never been in other parts of Louisville other than where our school is located. And, they've been pretty much their world while they're here in Louisville. And we had like a little celebration at the end. We brought in our whole research team, University of Louisville, UK, and different ones. And we brought in some of our city leaders as well, our politicians. And then the students began to talk about what it meant for them. And after hearing that, I was not sad that we used them. I was so happy. And to this day, we get a pretty good response from our students. Students are students, some are more enthusiastic than others. But overall, we've had a pretty good response with our students to this research.
I would say, and I know it's probably a little off-putting, I'm wearing a tie and all, but we do get together regularly as a
Yeah.
team, usually over a meal, and it's just so funny. And maybe I just am too old, but like the students, I mean, it's just so fun to see the Simmons students and the U of L students. They all have the same complaints, and they're all excited about the same things.
Yeah.
And I think it's just important to, kind of get these reminders that, I think a lot of barriers have been erected just that are psychological purely. And it's the thing that I enjoy the most about this work. I mean, sure, we're going to do some research, but, we really do like each other, and we are
Yeah, we
working
do.
together. And I think the work just gets better for it.
Well, Dr. Smith, Dr. C, thank you so much for that great presentation. A lot of the comments in the chat are just your praises of how helpful and great this presentation was. So I can't thank you both enough. Thank you to everyone who joined. Like I said, I will be sending out a link to the recording of this presentation along with instructions about how to get that certificate of attendance. So with that, have a great rest of your Thursday, everyone.